guys, so today we're going to talk about the PACU rotation, and you can see the objectives, and they're pretty extensive, but there are some specific things we're going to focus about more today and some in the in-class presentation. So what's the role of PACU? It really has two main roles. It's primarily designed to help us in caring for our patients right after surgery so they can recover from the immediate physiologic effects of the anesthetics and surgery. PACU beds can also serve as a critical care bed when the ICU is full, and it's been happening every once in a while here. It is mandatory for PACUs to be equipped to monitor and resuscitate any unstable patients, and at the same time provide a nice, tranquil environment for the recovery and comfort of stable patients. So it's kind of a duality of what the patients need in the PACU depending on how they present. So when we bring the patients to PACU, we gotta give all the pertinent information to the PACU nurse, like history, physical findings, any specifics of the anesthetic and surgery. Of course, there is specific focus on monitoring oxygenation with pulse ox, ventilation, like breathing frequency, airway patency, capnography, and circulation with blood pressure, heart rate, and ECG. In PACU, vital signs are recorded as often as necessary, but at least every 15 minutes while the patient's in the unit. Now remember, in the OR, the frequency is at least every 5 minutes, and in PACU every 15 minutes. Now, there are some specific PACU-related conditions that we need to pay attention to. During emergence from the anesthesia and surgery, we have to think about nausea and vomiting, the need for upper airway support, and systemic hypertension. And as you can imagine, serious outcomes are the result of airway, respiratory, or cardiovascular compromise. And in closed claim database, critical respiratory incidents make up for more than half of all the PACU malpractice claims. So airway, airway, airway. Also, you can't forget about the transport from OR to PACU. This is the time that we don't monitor the patient who are at real risk for airway obstruction and airway compromise. And I always tell the junior residents or medical students that when we're transferring from the operating room to the PACU, if you can talk to the patient and the patient has reasonable answers, the patient has adequate oxygenation, the patient has adequate blood pressure, adequate ventilation, and reasonable pain control. If a patient's not talking to you, then you got to start worrying about it and do more detailed assessment. And this is a table showing some physiologic disorders that can manifest in the PACU. So upper airway obstruction, hypoxemia, hypoventilation, etc. And we're going to talk more in detail.
So upper airway obstruction, as I told you guys, is extremely important in PACU, and I found a really good example of this on YouTube. Here we go.
Partial upper or lower airway obstruction alters the mechanics of breathing. Let's look at a patient to see some of these physical signs of obstruction. This 7-year-old girl is about to undergo tonsillectomy for enlarged tonsils and sleep apnea. She's breathing an anesthetic gas. As she loses consciousness, her muscles relax and she starts to obstruct her airway. Watch how the mechanics of her breathing changes. When a patient is working hard to breathe, the accessory muscles of respiration, the sternocleidomastoid and scalene muscles, tends to lift the clavicles and allow fuller expansion of the chest. These muscles become tense and rope-like. Look how the skin over the tracheal notch is sucked inward, an important sign of obstruction. The harder the patient tries to breathe against both upper airway or lower airway obstruction, the more negative pressure is created inside the chest. This pressure differential sucks the soft tissue between ribs and at the sternal notch inward. When the diaphragm descends maximally, it pushes the abdominal contents downward and outward, further decreasing intrathoracic pressure. If the airway is obstructed, no air can enter the chest, and this negative pressure pulls the chest wall inward. A rocking chest motion occurs, with the chest falling and the abdomen rising. This is the opposite of normal inspiratory motion. Other signs of airway obstruction can include poor movement of air in and out of the mouth and nose, nasal flaring, faint or absent breath sounds, head bobbing or grunting, and the inability of the awake patient to phonate. The anesthesia provider opens the airway by pulling up on the jaw, then inserts an oral airway. Look at the difference in chest wall motion now that obstruction is relieved. The chest and often the child's abdomen rise together with inspiration. Breath sounds are heard on auscultation. Air movement returns. When a clear mask is used, this air movement is seen as condensation inside the mask. Another important criterion is the color of skin and mucous membranes. Cyanosis is the bluish coloration of mucous membranes and skin due to deoxygenated hemoglobin in the blood vessels near the skin surface. It occurs when arterial oxygen saturation falls below 85%. The bluish skin color associated with cyanosis is a late and sometimes unreliable sign of hypoxia because ambient lighting, skin pigment, and severe anemia make it hard to see. An oxygen saturation monitor is much more reliable if you have one. The ability to manage airway obstruction and to ventilate the patient with a bag valve mask device are essential skills in patient management. Early intervention can and does prevent problems and improve outcomes.
Okay, so I thought that was a nice review of airway management and how to diagnose upper airway obstruction and proper airway management, at least in an acute setting. So, as you all must have seen, airway obstruction is very common and can cause some major complication in the post-op period. The most common cause of this obstruction in the PACU is the loss of pharyngeal tone in a sedated or obtunded patient. We lose pharyngeal tone because of the residual depressant effect of our inhaled and IV anesthetics and the persistent effect of neuromuscular blockers if not reversed or inadequately reversed. In an awake patient, the pharyngeal muscles contract synchronously with the diaphragm to pull the tongue forward and tend the airway open against the negative inspiratory pressure generated by the diaphragm. This pharyngeal muscle activity is depressed during sleep, so the reduced tone can cause airway obstruction. In inspiration, the pharyngeal tissue collapses during the inspiration. So, as a reflex, there is a compensatory increase in respiratory effort and negative inspiratory pressure, which can cause more airway obstruction. So, you can see that there can be a vicious cycle here. When patients try to breathe against an obstructed airway, you will see a paradoxic breathing pattern of retraction of the sternal notch and exaggerated abdominal muscle activity. There is a rocking motion of collapse of the chest wall plus protrusion of the abdomen with inspiratory effect. And the worse airway obstruction, the more rocking motion. And this was what we saw in the video just now. To fix this obstruction from loss of pharyngeal tone, we can open the airway with the jaw thrust maneuver or using a CPAP through a mask. You may need to use oral, nasal airway, or even put LMAs or intubate the patient if they're not responding. When evaluating upper airway obstruction in the PACU, first you gotta make sure paralytics have worn off or reversed. Residual paralysis can be hard to detect because the diaphragm recovers from the paralytics before the pharyngeal muscles do. So in an intubated patient, we look at end-tidal CO2 and tidal volumes, but they only tell us if we have adequate ventilation. But to be able to maintain a patent upper airway and clear upper airway secretions may not have happened yet. Patient may not be able to do that. We get the patient stimulated with extubation, transfer them from the OR to to their transport bed. And when they get in PACU, the patient is resting calmly. There's no more stimulation, so that's when they start obstructing more. Even patients treated with rock that's reversed with neostigmine can manifest residual paralysis in PACU. And this is primarily because of problems with train of 4. So gamma negatives can also, if you don't give an adequate dose, can have the same problem. We typically use train of 4 to assess reversal at the end of surgery. Now, you gotta understand that this is a subjective measurement and may not accurately reflect recovery of the pharyngeal tone because a decline in the train of 4 ratio may not be appreciated. You may not be able to recognize it. And usually when we can recognize it, it's about 0.4 to 0.5 change. But there can be significant clinical weakness when the ratio is 0.7 and pharyngeal function doesn't really return to baseline until the adductor polycystic train of 4 is greater than 0.9. So in other words, we can appreciate a 0.4 or 0.5 decline in train of 4. That's the highest we can see with our eyes. But when it's as high as 0.9, you may not have pharyngeal tone. So visual inspection is not adequate. When patients with residual neuromuscular blockade are awake in the PACU, their struggle to breathe may manifest as agitation. So in an awake patient, we can evaluate the patient by your clinical exam and train of 4. But if you do train of 4, that's going to mean it hurts, so do clinical exam. And this clinical evaluation includes grip strength, tongue protrusion, the ability to lift the legs off the bed, lift the head off the bed. And of all of these maneuvers, the 5-second sustained head lift is considered the gold standard because it reflects not only generalized motor strength, but more importantly, the patient's ability to maintain and protect the airway. In extubated patients, if they can strongly oppose the inside of their teeth against the tongue depressors, they can also have return of pharyngeal muscle tones. And this maneuver usually correlates with an average train of 4 of 0.85, so it gets pretty close. But if they can do the 5-second head lift, you're good to go. In any case, obstruction is less likely if we reverse the patient's with neostigmine or sugammadex. But if you suspect persistence or return of neuromuscular weakness in PACU, you have to think about other etiologic factors. And some of these common factors may be respiratory acidosis and hypothermia, and they do happen quite often. Residual depressant effects of your volatile anesthetics, opioids, or both can cause a progressive respiratory acidosis only after the patient is admitted to the PACU and we're not stimulating them anymore. Also, a patient who gets hypothermic during anesthesia and surgery may show signs of weakness in the PACU that were not noted on extubation or in the OR. Simple measures like warming the patient, airway support, and correction of any electrolyte abnormalities can really make this recovery from neuromuscular blockade go smoothly. Now, laryngospasm is when we have a sudden spasm of the vocal cord that completely occludes the laryngeal opening. It typically occurs in a transitional period when the extubated patient is emerging from general anesthesia. And although it is most likely to occur in the OR at the time of extubations, patients who get to PACU sleep after general anesthesia are also at high risk of laryngospasm when they're waking up. So when you're working with me, we do a deep emergence. Typically, I leave an oral airway in until we get to PACU and the patient's waking up to the point that I can take the oral airway out. So typically, I like to stay with the patient until the oral airway is out and the patient's awake enough to maintain the airway. But if you can't, you got to start worrying about it. Usually, jaw thrust with a CPAP of about up to even 40 centimeter water is enough to break any laryngospasm. But if jaw thrust and CPAP maneuvers fail, we gotta use paralytics and succinylcholine doses of as low as 0.1 to 1 milligram per kilo in the IV or 4 milligram per kilo IV can fix the problem. And it's extremely important to remember that we shouldn't force an endotracheal tube through a glottis that is closed because of laryngospasm. It causes major glottic trauma, and you should not do that. So here's a video of laryngospasm, so take a quick look.
Now he don't.
You hear the striders, and take a look here with inspiration, all the negative pressure that's needed to be able to move the air in. Here's another one. Can hear the striders much better here. And again, look at the diaphragm here. And also, did you see the accessory muscle movement in this patient? So, as I said, laryngospasm typically occurs in a stage 2 or disinhibited stage. And historically speaking, these are the stages of anesthesia. So stage 1 is analgesia, so there's no pain awareness, there's amnesia, consciousness is usually not lost, but it may be impaired. Stage 2 is disinhibition, so a little bit deeper than the analgesic stage. So patients can be delirious, excited, they're amnestic, they have enhanced reflexes, so if something goes down, touches the cord, normally you would cough, but in this stage, instead of coughing, the cords have an exaggerated response of laryngospasm. They can have irregular respiration and incontinence. Stage 3 is a surgical anesthesia, and patients are unconscious, there's no pain reflex, they have regular respiration, and blood pressure is maintained. Stage 4 is the deep level, and that's where we have medullary depression. And there is severe cardiovascular and respiratory depressant, and the patient needs pharmacologic and ventilatory support to stay alive in this stage. Now, keep in mind, this is the stages of anesthesia that's historically described with ether. In modern anesthetics, these are not really there anymore, and the stage 2 may be present for a very brief period of time. So there are some people who actually argue, like when you use desflurane, sevoflurane, or isoflurane, there is no real thing as stage 2. But no, I still believe that it is, and it's just not as exaggerated as it would have been with ether. Oops. So, what about airway edema? We can see airway edema in patients after long procedures, especially if they're in prone or Steve Trendelenburg position, and also when there's been a large amount of blood loss, and we normally treat that with fluid resuscitation. Also, surgeries on the tongue, pharynx, and neck, thyroidectomies, carotid endarterectomies, cervical spine surgery, they can all cause upper airway obstruction because of tissue edema or even hematoma. And typically, we don't see pharyngeal edema externally, right? It's all inside. So if you're planning to extubate a high-risk patient, we have to evaluate airway patency first. This is where leak test comes into play. If the patient can breathe around the endotracheal tube, where the balloon is down and you put your thumb on the endotracheal tube, you occlude the tube, and we should be okay. So basically, you do this maneuver, balloon down, occlude the tube. If the patient can breathe around the tube, that's fine, we're good to go. There are some other ways to do this. You can do it by measuring the intrathoracic pressure that's required to produce an audible leak around the endotracheal tube when the cup is deflated, or you can measure the exhale tidal volume before and after endotracheal tube cup deflation in a patient receiving volume control ventilation. Typically, I like to do this. It's a little bit easier, so I don't have to change anything or move anything, and if I don't have access to my endotracheal tube far away from me, or it's hiding under the drapes, this is a little bit easier. So you can see your tidal volumes, you're on volume controlled, and you take down the balloon, and then you look at the differences, and you look at the leak around the cuff. Works kind of nice. But don't forget that none of these cuff leak tests take the place of your clinical judgment when deciding to extubate the patient. So if you're worried about airway compromise and you have a leak test that's patient passes, if you're still worried, don't extubate the patient. Your clinical judgment is more important. Nowadays, it feels like that everyone has sleep apnea, but we have to watch out for patients with OSA in the PACU. And these patients are particularly prone to airway obstruction, so we should not extubate them until they're fully awake and following command. This is when I tell my residents that this is a Chris Chase extubation. The patient is fully awake, following command, then you extubate. Patients with sleep apnea, they have redundant and compliant pharyngeal tissue, so the risk of airway obstruction and difficult intubation is even higher. Once in the PACU, an extubated patient with sleep apnea is very sensitive to opioids, so use regional analgesia if you can. Benzos can have a more intense effect on their pharyngeal muscle tone than opioids, so really watch out for them. When caring for these patients, you should have a plan preoperatively to have them on CPAP as soon as they're awake. And if your patient is the most common type of sleep apnea patient who is non-compliant with their CPAP, you may actually need to call the respiratory therapy and plan for the patient to have CPAP in the post-op time. And as you know, the majority of patients with mild to moderate sleep apnea are undiagnosed. So we have to focus on the risk factor before we induce them and pay special attention to history of snoring and daytime sleepiness. So how do we assess them? Stop bang, that's the most common one, and it actually works quite nicely. So the stop part, do you snore? Yes or no? Do you feel tired? Has anyone observed you stop breathing at night? And do you have high blood pressure? Bang part, BMI of more than 35, age more than 50, and neck circumference of over 40 centimeter, and gender if they're male. And if the patient answers yes to more than 5 of these, the patient is high risk for having sleep apnea. And if that's the case, I assume they have sleep apnea. And less than 2, patient doesn't have sleep apnea, much less likely. So you plan accordingly based on this stop bang. And most of these you can just have an idea based on your interview with the patient. So if the patient is a guy, you already have 1. If over 50, you already have 2. If the patient is obese, you have 3. You can look at their neck. If they have a thick neck, now you're 4. They have a history of hypertension. They're already at 5. Do they look tired? Do they look sleepy? That may or may not be contributing. But we already at 5. We have all of these quite easily just by looking at the patient and talking to them. So what do you do when there is a patient in PACU with airway obstruction? And you have to open the airway first by using non-invasive techniques. So you start with jaw thrust, give CPAP, 5, 15 centimeter water CPAP, even higher. And if CPAP is not effective, you put in an oral airway or a nasal airway, or if that doesn't work, you put in an LMA. When the airway is open and patient's ventilating, you got to find the cause of obstruction and treat it. So reverse the opioids with opioids and benzos. The first thing to reverse them with is stimulation, wake the patient up. That doesn't work, you use pharmacologic agent. Use Narcan, 0.3 to 0.5 milligram per kilo, or flumazenil. You reverse the paralytic or correct any contributing factors like hypothermia. If you can't mask ventilate a patient with severe upper airway obstruction from edema or hematoma, you may have to decompress the airway by releasing the clips or sutures on the wound and evacuate the hematoma. So yes, a carotid endarterectomy patient, hematoma of the neck, airway compromise, we have to open the neck. Ideally in the OR, but if the patient is decompensating in PACU, you have to do that in PACU. If everything has failed and you have to intubate emergently, expect them to be difficult airway and make sure that you have surgical backup. So if you need to do a crike or a trach, somebody else can help you. And if the patient is able to move air by spontaneous ventilation, you can do awake intubation. Because in these cases, visualization of the course by DL may not be possible. Everything looks different, and especially in post-op patients with lots of trauma, hematoma, edema, things don't look normal. So when you do awake intubation in them, you follow the bubbles to intubate them, and it actually works more smoothly than you would imagine. The other thing is the transport. Transport is a dangerous time when we go from OR to PACU. We have to monitor the upper airway patency and respiratory effort. We give everyone oxygen in transport. So if you have pulse ox, you may miss hypoventilation. And by the time saturation starts going down, you're entitled your arterial CO2 maybe in the hundreds. So watch for the appropriate rise and fall of the chest wall. Listen for breath sounds, or simply put your hand under chest and feel the chest rise. Even better, you can put your hand under mouth and feel for the movement of air. Hypoxemia in PACU is also one of the common things that you see, and especially if you don't use supplemental oxygen. So, in the post-op period, the most common causes of hypoxemia are really atelectasis and to some extent alveolar hypoventilation. Diffusion hypoxemia or hypoxia used to be an issue, but we now have the patients on high FiO2 when we extubate them and run supplemental oxygen for the most part right after. So diffusion hypoxia is not really common anymore. But if a patient is persistently hypoxemic, you have to find out the cause and look at their history, operative course, clinical signs, and symptoms to figure out the workup. On the table, you can see other causes of hypoxia, and we will delve into more detail on the more common ones and more highly tested ones. In alveolar hypoventilation, patients may have low minute ventilation because of depressed drive to breathe or generalized weakness from residual paralytics or underlying neuromuscular disease. There may be restrictive pulmonary conditions like chest wall deformity, post-op abdominal bindings, or even abdominal distension. As you remember, the alveolar gas equation can show how hypoventilation alone is enough to cause arterial hypoxia in any patient breathing room air. And yes, you need to remember this. So let's see an example of why it is useful. So at sea level, in normocapnic patients breathing room air, when you apply the alveolar gas equation, you get PaO2 equals FiO2, which is 21% or 0.21, multiplied by 760, which is barometric pressure, minus 47, which is the pressure of water, minus CO2. Let's assume this is normal CO2, so 40, divided by respiratory quotient, which is 0.8. And when you do the calculation, so at sea level, somebody breathing room air with normal CO2, we can see as oxygen, arterial oxygen of 100 millimeter of mercury. Now, let's increase the CO2 from 40 to 80. So you do the same calculation, and instead of for PCO2 over respiratory quotient, instead of putting 40, you put 80 in there. And you get a 50 millimeter of mercury for your oxygen. This is hypoxemia. So what would be your SpO2 in this level? Remember 90, 80, 70 rule, 60, 50, 40. So if SpO2 is 90, your PaO2 is going to be 60. If it's 80, your PaO2 is 50. If it's 70, your PaO2 is 40. So here our PaO2 is 50. So your saturation is going to be 80%. Again, this is not entirely perfectly correct, but for it's within reasonable approximation. So you can reverse this, right? So if you give supplemental oxygen, patient saturation and oxygen level goes back to normal. If you normalize the PCO2, patient also gets back to normal. So normally, minute ventilation increases by about 2 liters a minute for every 1 millimeter increase in arterial CO2. So if your arterial CO2 is 50, your minute ventilation should go up by 2 times 10, which is 20. So that's going to be pretty significant. But this linear ventilatory response to CO2 is depressed in the immediate post-op period because of the residual effect of your inhalation anesthetics, opioids, and sedative hypnotics. You already depress the respiratory drive, so you don't see this massive increase in minute ventilation when CO2 goes up. But arterial hypoxia from hypercapnia alone can be reversed by giving supplemental oxygen, by normalizing PCO2 or both, as we already talked about. So in the PACU, arterial CO2 can be returned to normal by stimulating the patient, reversing the opioid or benzos, or put the patient on controlled ventilation. This is the graph that shows what happens to alveolar CO2 as minute ventilation drops, or conversely, what happens to your minute ventilation as alveolar CO2 goes up. So the lower minute ventilation, the more hypercapnic the patient is going to be. That makes sense. You hold your breath, your CO2 goes up. Now here the percentage point is the FiO2 that is required to prevent the hypoxemia at a specific minute ventilation. So as you can see, if minute ventilation is 1 liter a minute, which is completely inadequate for any extubated adult in the PACU, your CO2 will go over 100 millimeter of mercury. And if you have nasal cannula at 6 liter a minute, you wouldn't have any drop in your SpO2, because 6 liters a minute is over 40% FiO2. So this can be very dangerous because CO2 keeps going up and up. We used to see diffusion hypoxia a lot more in the past, but it can still be an issue every once in a while. When we use nitrous, we can have rapid diffusion of nitrous oxide into alveoli at the end of a nitrous oxide anesthetic. And this is diffusion hypoxia. Nitrous oxide dilutes the alveolar gas, so you get a transient decrease in alveolar oxygen and alveolar CO2. If the patient's breathing room air, the decrease in alveolar oxygen causes hypoxemia. Excuse me. And without supplemental oxygen, diffusion hypoxia can last for about 5 to 10 minutes after a nitrous oxide anesthetic. So to understand VQ mismatch in shunting, you really need to understand hypoxic pulmonary vasoconstriction, or HPV. HPV is an attempt of normal lungs to optimally match ventilation and perfusion. So we get vasoconstriction of vessels in poorly ventilated regions of the lung, so we can send pulmonary blood flow to well-ventilated alveoli, so they can participate in gas exchange. The hypoxic pulmonary vasoconstriction response is inhibited by a number of conditions and medications, like in pneumonia, sepsis, and vasodilators. In the PACU, the residual effects of the inhaled anesthetics and vasodilators like nipride or nitroglycerin, dobutamine will blunt this pulmonary vasoconstriction and contribute to arterial hypoxemia. Interestingly, phenylephrine augments this hypoxic pulmonary vasoconstriction response, but this is probably not clinically significant. It's more like a interesting lab finding. The mechanism of hypoxic pulmonary vasoconstriction is very interesting, as you can see in the figure. Hypoxia closes the voltage-gated potassium channel, so potassium ion accumulates intercellularly. This leads to depolarization of the cell, which opens voltage-gated calcium channels and calcium-mediated pulmonary vasoconstriction. So you get vasoconstriction. VQ mismatch is the most common cause of hypoxemia. Normal VQ ratio is 0.8. And as you remember from vest zones of lungs, there is regional heterogeneity of VQ ratio that is caused by variable subatmospheric intrapleural pressures and gravity. Both ventilation and perfusion are higher at the base and lower at the apex of the lung. So think of it, gravity increases both ventilation and perfusion. But the ratio of VQ is higher at the apex and lower at the base. This is because the rise in perfusion is much more than the rise in ventilation because of the pull of gravity. The VQ ratio is higher at the apex because the fall in perfusion is higher than the fall in ventilation at the apex, again because of the gravity. Since ventilation is responsible for gas exchange, apical regions with high ratio have low alveolar CO2 content and high oxygen content, and in the basal region as low alveolar oxygen content and high CO2 content. So in dead space, we have ventilation, but there is no perfusion or blood flow. So our VQ ratio is V divided by 0, which would be infinity. As you can see in the figure, when we have more ventilation than perfusion, our VQ ratio keeps going up because the flow or Q gets smaller, and when we reach 0 blood flow, we have dead space. In terms of VQ mismatch, as we get less ventilation, our VQ ratio drops, and if we get to a point where there is 0 ventilation, our VQ ratio becomes 0. This is shunt. Unlike a typical VQ mismatch, a true shunt will not respond to supplemental oxygen. And common causes of post-op pulmonary shunt include atelectasis, pulmonary edema, gastric aspiration, pulmonary emboli, and pneumonia. And of these, atelectasis is the most common cause of shunting in the post-op period. So to decrease atelectasis, we need to get the patient sitting up using IS or instead of spirometry and positive airway pressure by face mask or mechanical ventilation if needed with positive pressure. Increased venous admixture typically refers to a low cardiac output state because we get mixing of desaturated venous blood with oxygenated arterial blood too. Normally, we get about 2 to 5% of cardiac output shunted through the lungs with minimal effect on arterial oxygen concentration. But in low cardiac output states, blood returned to the heart severely desaturated. So instead of being, 75, 80% desaturated, it's going to be 50% desaturated. We also get more shunt fraction with conditions that also impede alveolar oxygenations, like pulmonary edema and atelectasis. So mixing of this desaturated shunted blood with saturated arterialized blood decreases your PaO2, arterial O2, and causes hypoxemia.
So let's talk about pulmonary edema next. Pretty much all the pulmonary edema in the early post-op period is cardiogenic because of volume overload or cardiac dysfunction. We can also get pulmonary edema in PACU from aspiration or sepsis. And rarely we can get post-op pulmonary edema from airway obstruction, and this is the post-obstructive pulmonary edema, or we can get TRALI from transfusion of blood products. Post-obstructive pulmonary edema or negative pressure pulmonary edema is a rare cause of hypoxemia in PACU. And it is a transitive edema that happens because of the exaggerated negative pressure generated by inspiration against a closed glottis. And this exaggerated negative intrathoracic pressure increases the venous return, which also causes the transudation of fluids in the lungs. And the highest risk patients are muscular, healthy patients because of their ability to generate significant inspiratory force. So essentially, patients have like an episode of laryngospasm and they try to inhale, so they generate a huge negative inspiratory pressure, but the glottic opening is closed, so nothing can come out. So when that negative pressure happens, the fluid is transudated from the capillary beds in the lungs in the interstitium. So the stereotypical patient usually has laryngospasm, but it can also happen whenever anything occludes the upper airway, like biting on the endotracheal tube. So typically we see hypoxemia within about 90 minutes after the obstructive event. And if you do an X-ray, you will see bilateral fluffy infiltrates. And you can see here the bilateral infiltrates, and it's a pretty significant pulmonary edema in this patient. And the treatment for this is really supportive. So we give them supplemental oxygen, we give them diuretics, and in severe cases, you need to intubate them and do positive pressure ventilation. In PACU, when you suspect pulmonary edema and the patient's got blood, coagulation factors, or platelets, you have to think of TRALI, and really anything that contains plasma. The symptoms of TRALI usually shows up in about 1 to 2 hours after the transfusion, but it can be delayed up to 6 hours. And typically patients present with non-cardiogenic pulmonary edema with fever and systemic hypotension. And if you do a CBC, you can see a drop in white blood cell. And this is from the sequestration of granulocytes into the lungs and exudative fluid. This is a clinical diagnosis with the appearance of bilateral pulmonary infiltrate and increased alveolar to arterial oxygen difference, the AA gradient, and that's temporarily related to transfusion. Initially, it's pretty hard to distinguish trolley from TACO. TACO is the transfusion associated circulatory overload that's caused by the volume of the blood product that's transfused. But in both cases, treatment is supportive, so you give them supplemental oxygen, diuresis, etc. Topics when it comes to PACU, because almost everyone will tell you that we need supplemental oxygen in the post-op time. But this is really controversial. Of course, if somebody is hypoxemic, we need to use oxygen, but we don't really know what is the optimum perioperative oxygen requirements. We don't know if increased oxygen delivery actually reduces the incidence of post-op nausea, vomiting, or wound infection because there are lots of studies on the topic, but there are mixed results. So how do you choose the oxygen delivery device? Again, really, it's common sense based on the degree of hypoxemia if present, the surgical procedure, and specific patient issue, like if somebody really doesn't like nasal cannula. So in procedures like in head and neck cases with flaps, you may not be able to use a mask because it could compromise the flow to the new flap. Or if there's nasal packing, you can't really use nasal cannula. Again, common sense. The most oxygen you should deliver with a simple nasal cannula should be 6 liters a minute. Because if you increase the flow more, it gets really uncomfortable for patients and can really dry the nasal mucosa. And as a general rule, each liter a minute of oxygen flow through a nasal cannula increases your FiO2 by 4%. So when you do 6 liters a minute, we can deliver 21% plus 6 times 4, which is 24. That's roughly 45% FiO2. We can deliver higher rates with masks, but even with non-rebreather mask, we can have problems because of inadequate mask fit or high ventilation requirement that sucks the room air into it. But if we use a high flow nasal cannula, we can actually deliver as high as 40 liters a minute and newer version 60 and 90 liters a minute. And they humidify and warm the gas to almost 100% relative humidity and 37 degrees Celsius. These are much more efficient than the non-rebreather mask and can deliver almost 100% FiO2. In the past, about 8 to 10% of patients would fail extubation after any abdominal surgery because of hypoxemia. Since the use of CPAP in the PACU, these numbers have gone down quite a bit, and they have also reduced incidence of pneumonia, infection, and sepsis. Usually in the immediate post-op, we tend to avoid non-invasive possible pressure ventilation because they can cause gastric dissection, aspiration, and wound dehiscence, especially in patients after gastric or esophageal surgery. Specific contraindications are hemodynamic instability or life-threatening arrhythmias, altered mental status, high risk of aspiration, inability to use a nasal or face mask like head and neck procedures, and refractory hypoxemia. From PACU nurse that the patient's hypertensive, hypotensive, tachycardic, bradycardic, etc. And as you can imagine, the hemodynamic instability in the post-op period should worsen the outcomes, and it does. But it is the post-op hypertension and tachycardia that's more predictive of unplanned admission to ICU and increased mortality and morbidity compared to hypotension and bradycardia. So if you work with me, you know I like V equals IR. And if you remember this equation, you can answer any questions when it comes to hypotension, hypertension, etc. So the equivalent of V or potential inside the human body is your MAP. The equivalent of current is cardiac output and resistance is systemic vascular resistance. So if you convert that, you would write MAP equals cardiac output times systemic vascular resistance and divided by 80 to get the units right. So if somebody is hypotensive, so MAP is low, it can only be low cardiac output or low SVR. If it's low cardiac output, it can be only low stroke volume or heart rate or contractility that comes into play here. If it's low stroke volume, it's about your end diastolic volume or end systolic volume. That's all that could cause your blood pressure to go up or could make it go low. So if you remember V equals IR, you can answer any of these questions. And for your board question, you can use the same equation but convert them for pulmonary catheter questions. Patients with a history of essential hypertension are at greatest risk for any significant hypertension in the PACU. But other causes of hypertension include pain, hypoventilation, which causes hypercapnia, emergence excitation or emergence delirium, advanced age, history of smoking, and any pre-existing renal disease. Also, specific procedures that increase your risk of post-op hypertension include lots of procedures, but cranies and carotid endarterectomy are the most common ones. Post-op hypotension can be characterized into three categories of hypovolemia, cardiogenic, or distributive hypotension, or shock, essentially. In terms of cardiogenic hypotension or hypovolemic hypotension, the most common cause in the PACU is decreased intravascular fluid volume and preload, and so the response to intravascular fluid. The most common causes of decreased intravascular volume in the post-op period are ongoing third space losses, inadequate fluid replacement, and loss of sympathetic tone that happens with our neuraxial techniques. Of course, we need to rule out persistent bleeding in a hypotensive patient, so you got to check the hemoglobin in the unstable patient. Don't rely on tachycardia as a sign of hypovolemia or anemia, since there's so many of our patients that are taking beta blockers or calcium channel blockers, so it's not sensitive. If the cause of hypotension is cardiogenic, it is from myocardial ischemia and infarction, cardiomyopathy, and cardiac dysrhythmias. Your differential should depend on the surgical procedure, the intra-op course, and the patient's pre-op medical history. So this is when you gotta think about doing an echo, because that can answer so many of your questions. We cause sympathectomies with our regional techniques, and that can cause hypotension. If you block a patient to a T4 level, you will decrease the vascular tone as well as the cardio accelerator fibers. And if you don't treat it, the bradycardia combined with the severe hypotension can lead to cardiac arrest, even in young healthy people. So given pressors, phenylephrine, ephedrine, when it comes to the critically ill patients, you have to be really, really careful. They tend to stay alive because of their exaggerated sympathetic system tone at baseline just to maintain their systemic blood pressure and heart rate. In these patients, even a minimal dose of inhaled anesthetic, opioid, or sedative hypnotic can decrease their sympathetic nervous system tone and produce significant systemic hypotension. So when I was a resident, I had a patient who needed a it was a hip fracture repair, and a guy who had an MI a week before. Don't ask me why we were operating. I was a resident, that wasn't my choice. But he came to the operating room, and moved him to the operating room bed, put our monitors on. I had my A-line in, and his heart rate baseline seemed to be in the low 100s, like 110. So I wanted to see, what happens if I bring the heart rate down a little bit, because he just had an MI. So gave him 10 milligram of esmolol, 1 ml. And this guy's heart rate came down to like 80s, and his pressure tanked. You can imagine how the rest of the procedure went. You should think about anaphylaxis whenever there is a sudden refractory extreme hypotension, even when there is no bronchospasm or rash. So in this patient, if you order serum histamine or serum tryptase, within 30 to 120 minutes, you can confirm an allergic reaction. But this doesn't differentiate anaphylactic from an anaphylactoid reaction, which doesn't really make a difference for us in terms of immediate treatment. But remember, serum tryptase takes several days to come back. So it's not for an immediate diagnosis. The most common cause of anaphylactic reactions in the OR are neuromuscular blocking agents, but in the US, it is antibiotics. Don't forget about epinephrine as the first drug to treat this. If you suspect sepsis, though, in PACU, you got to send for blood cultures and start empiric antibiotic therapy before leaving the PACU. Specifically, patients can get septic quickly enough for us to see them in PACU after urinary tract manipulation and biliary tract procedures. And they usually present with hypertension, fevers, and sometimes rigors. In terms of MI, Diagnosing MI in PACU is not that straightforward because patients can't really tell us their symptoms. Typically, less than 20% of these patients with MI have chest pains in PACU. Also, using the bedside monitors, the telemetry, are quite inaccurate in showing SD changes. This is why we have computed SD segment analysis in the PACU, and if you have any concerns, you just gotta order a 12-lead EKG, and we do that pretty quickly. Pericardiac dysrhythmias are usually transient and multifactorial, as you can imagine. Some specific reversible causes in the periop period are hypoxemia, hypoventilation, and associated hypercapnia, endogenous or exogenous catecholamines, electrolyte abnormalities, acidemia, fluid overload, anemia, and substance withdrawal. But there are so many other causes that, as you can see. You determine how to treat the dysrhythmia based on patient symptoms. Tachydysrhythmias decrease your diastolic and coronary perfusion time and increase myocardial oxygen consumption. Its impact depends on the patient's baseline cardiac function, and it's most harmful in patients with coronary artery disease. Bradycardia is more dangerous in patients with a fixed stroke volume, so in infants, patients with restrictive pericardial disease, or cardiac tamponade. We didn't that much focus on it in the PACU, but we should be. About 10% of patients older than 50 who have any elective surgery would experience some degree of post-op delirium in the first 5 days. That's 10%. The incidence is much higher in some procedures like hip fractures and bilateral total knees. Don't forget about your differentials. As you can see on the table, it could be anything from atrial hypoxemia, hypoventilation causing hypercapnia, drug withdrawal, electrolyte abnormalities, infection, etc. Persistent post-op delirium is generally a condition of the old patients, the elderly. It is a costly complication and it increases your length of stay, pharmacy costs, and mortality rates. But we can predict the patients at risk. The most common and significant pre-op risk factors are advanced age, pre-op cognitive impairment, decreased functional status, alcohol abuse, and previous history of delirium. In addition to iatrogenic factors like inadequate hydration and medication, your workup should rule out hypoxemia, hypercapnia, pain, sepsis, and electrolyte abnormalities. Intra-op factors that increase your risk are surgical blood loss, hematocrit less than 30, and the number of intra-op blood transfusions. So we must identify the high-risk patients before getting to PACU. We're going to need restraints and additional personnel to control the patient if they're severely agitated. And early ID identification of patients at risk can also guide the pharmacologic therapy postoperatively. So alcohol or opioid dependent patients will probably need more opioids to treat their pain and anxiety and avoid the onset of alcohol withdrawal. On the other hand, in the elderly population, we need to limit our drug therapy and use smaller doses as much as possible to avoid further exacerbation of drug-induced delirium. So you gotta, if you don't notice ahead of time, you do increase your risk. Emergence delirium or emergence excitation is a transient confusional state that's associated with emergence from general anesthesia. It's pretty common in children, and it can happen with incidence of as high as 30%. And the peak age for this emergence delirium in kids is between 2 and 4 years. Unlike the typical delirium, emergence delirium resolves quickly and is followed by uneventful recovery. It is more common with rapid wake-up from inhalational anesthetics, and medication with midazolam has been associated with an increased risk in some studies, but this is probably from pre-op anxiety state or other factors. In fact, most believe that pre-op midazolam decreases the risk of post-op delirium. Opioids are also believed to reduce the incidence, but the data is minimal and it's controversial. Clonidine has good data behind it, and also parenteral calmness is a good predictor of reduced risk of post-op emergency. Post-op nausea vomiting is one of the topics that very near and dear to my heart, and I do anything in my power to decrease the risk of my patients because it sucks to be puking right after a big surgery or any surgery really. Again, post-op nausea vomiting is also a big deal in PACU. Patients with POMV have delayed discharge from PACU, unanticipated hospital admission, increased incidence of pulmonary aspiration, and worse pain control. So we must identify the high-risk patients and use appropriate prophylactic treatment to improve their care and also their satisfaction from the care that we give them in our PACU. So these are the most commonly coded risk factors, but there are so many other risk factors. The most significant ones are history of POMV or motion sickness, female gender, post-op opioid requirements, and non-smoking status. Also, other risk factors are gastric distension with swallowed blood or air, type of surgery like eye surgery, first strabismus, middle ear, laparoscopy, GYN, etc. The longer the surgery, the higher the risk. Also, use of some anesthetic drugs like nitrous, any inhalational agents, and opioids intraoperatively. For the most part, we can group these risk factors into patient factors, anesthetic factors, and surgical factors. And the most significant patient-related factors are female gender, post-puberty female, non-smoking status, childhood after infancy, and history of motion sickness or POMV. Now, anesthesia-related factors are the use of any volatile anesthetics or nitrous, giving large doses of neostigmine, and perioperative opioid use. The most significant surgical factor is really the duration of surgery. Now, this is the calculation that most people use based on a modified Apfel score. So you assign 1 point each for female gender, history of motion sickness or POMV, non-smoking status, and the use of post-op opioids. As you can see, the higher the number of risk factors, the higher your risk of POMV. So you need to use the number of risk factors to choose your antiemetic. Now, I have modified the Stanford POMV calculator for appropriate management of POMV for patients with specific risk factors. So if you have no risk factors, your risk of POMV is about 9%. So you should use one antiemetic, or some people say 0 to 1. If you have one risk factor, your risk of POMV is 20%. So use Zofran. If you have two risk factors, it's almost 40%. So you got to use two drugs from two different classes. If you have three risk factors, your risk of POMV is 60%. So you got to use three. If you have four, which is, in my experience, a significant number of female GYN patients, your risk of POMV is 80%. So use your Zofran, Scope Patch, Decadron, and do Tiva. So when is the best time to give your drugs? This is one of my pet peeves, especially when I come in the room and I see that they gave Zofran in the beginning of the case. So for Zofran, the best time to give it is 15 minutes before wake up. For Decadron, it's a steroid, it takes longer, so you got to give it an induction. Scopolamine is a patch, takes a long time to go through the skin and get to the circulation, so ideally 30 minutes to an hour before induction. Now, the question I have is, with low-dose propofol infusion decreases your risk of POMV after general anesthetic with inhalation anesthetic? The answer is absolutely not. When we do Tiva, it's the absence of inhalation anesthetic that decreases your risk of post-op nausea vomiting. It's not the propofol. Propofol is a powerful treatment for nausea, but it's not a prophylactic measure.
Renal dysfunction happens more often than we think about, so this is something that I'd like to focus on in the operating room, and especially with longer cases. Every 30 minutes at least urine output, at least every hour urine output should be measured. It can give you some interesting insight into what's going on with the patient. And the differential diagnosis for your post-op renal dysfunction are really renal, intra-renal, and post-renal causes. But usually it's multifactorial, and it's with a patient that's already had some pre-existing renal disease that gets exacerbated by some intraoperative insult. So in the PACU, we need to focus on our workup to really reverse any reversible causes of oliguria. What's oliguria? It's the urine output of less than 0.5 ml per kilo per hour. For example, what's the most common cause of urinary retention in a patient with a Foley catheter? It's Foley obstruction or dislodgement. And a few years ago, I had a patient that was having an aorta bifem, I think. And everything was going as expected in the first couple of hours of the surgery, but then he stopped making urine. My differential was pre-renal, post-renal, and renal. Post-renal is the easiest, so I had the nurse flush the Foley catheter and nothing happened. It worked fine. I also asked the surgeon if the bladder is full, and they said no. So I was left with pre-renal and renal. For renal, which is usually the hardest one and the most difficult to diagnose, I didn't have any reason to think of renal ischemia, nephrotoxic agents, rhabdo, or hemolysis. For pre-renal, I wanted to make sure that he wasn't hypovolemic, so I looked at my PPV, pulse pressure variation, and CVP, which were normal. He was completely hemodynamically stable, and there wasn't much blood loss during the case. I had no reason to think about low cardiac output or intra-abdominal hypertension. His belly was open. But I still asked to get a TEE because I was out of answers. I didn't know what was going on. Before I got a chance to put my TEE probe in, the surgeons told me that they had both the ureters cut. So you can imagine, had we not realized the urine output and didn't pay too much attention to it, they wouldn't have known, and the patient would have come back to the OR with worse outcomes. Post-op shivering is a common consequence of general and epidural anesthesia, and it happened as much as 65% after general anesthesia and 33% after epidural anesthesia. And interesting, the most common risk factors are male gender and the specific drugs that we use for anesthesia, like propofol. But beside discomfort that shivering causes, it also causes increased CO2 production and O2 requirement, which can cause sympathetic stimulation, and in a cardiac patient, it actually worsens outcomes. Even after prolonged surgery and anesthesia, patients should wake up in 60 to 90 minutes after. When delayed awakening occurs, we need to make sure we have normal blood pressure, arterial oxygenation, ECG, and temperature, and we need to do a neuro exam as well as we can. We can use a pulse ox and ABG to rule out hypoxemia and hypoventilation. You need to check sugars and electrolytes, and may even need a CT scan to rule out an acute intracerebral event. But really, the most common cause of delayed emergence in our non-responsive PACU patient is our drugs. So if you think it's opioid, titrate doses of IV naloxone, 20 to 40 milligram increments in adults. If you think it's from anticholinergic effect like scopolamine, use physostigmine. If you think it's benzos, give flumazenil. But don't delay CT scan if you think the patient may have had an intracerebral event, since you're really on the clock, and the sooner we diagnose it, the better the result. I'm gonna briefly talk about the major concepts of discharge criteria from PACU, but you guys should really read about the ASPAN criteria, ASPAN, on your free time. Specific PACU discharge criteria varies from hospital to hospital, but there are some common themes. So, there is no mandatory minimal stay in PACU, and patients must be observed until they're no longer at risk of ventilatory depression. That makes sense. Patient's mental status should be clear and return to baseline. Hemodynamic criteria are based on the patient's baseline hemodynamics without any specific systemic blood pressure and heart rate requirements. And to facilitate PACU discharge, there's some discharge scoring system that have been developed and modified over time to reflect current technology and anesthesia practice. The ASA standard of care requirement that a physician accepts responsibility for discharge of patients from the unit. So this is an example of a scoring system, and based on the scoring system, if a patient achieves this score of at least 9, they're ready for discharge. So the variables they look at, so vital signs should be essentially consistent with age or pre-anesthetic baseline. So if you're within 20%, you get the full point. If you're 20 to 40%, you get 1 deduction. If you're more than 40% off the baseline, you get 0 score. In terms of activity level, if you're at the pre-anesthetic level, you get 2. If you need some assistance, you get 1 point deduction. And if you can't walk, if you weren't able to walk before, If you were able to walk before, you get 0 points. In terms of nausea, vomiting, if you have none to minimal, you get the full point. If you have moderate, you get 1 deduction, and severe, despite treatment, you get 0 points. In terms of pain, you get 2 points. If the pain is controlled with oral, if it's not, you get 1 deduction. In terms of bleeding, again, same thing. If it's minimal to none, you get full points. And if it's 0, if you get severe bleeding, you get 0 points. So this all adds up. So patients should really be able to be at or very close to the baseline state for everything to be able to get discharged from PACU, especially for going home. But really, there should be a logical timeline. So you can imagine if the patients have a toenail surgery under local lung sedation, they should be able to go home pretty quickly. So this is where phase 2 comes in. Tonsillectomy in a 3-year-old kid, not the same thing. We gotta watch them quite a bit longer, and especially in younger kids, we have to keep them in the hospital. Inguinal hernia of a local sedation can go home pretty quickly. But if it was an inguinal hernia that was converted to general because the patient was vomiting, we keep the patient a lot longer and maybe even keep in the hospital overnight for observation. Again, inguinal hernia under general anesthesia, probably not that different from the sedation case, but probably takes longer to wake up from general anesthesia. Cataract surgery, pretty quickly because we give them hardly any drugs. Aortic stent for AAA, so they should meet the discharge criteria pretty quickly, but they have to stay flat, so we can't get them out within the first couple of hours or 3 hours, depending on the cardiologist or the vascular surgeon. Open AAA repair, completely different story. We technically don't even go to PACU, but if you verge into PACU, you have to watch the patient to make sure everything's getting close to normal, and it takes a long time. That's why we go to ICU for these. All right, thanks for listening, and I'll see you guys in the class.